Welcome back to those of you who've been with us for the entire afternoon, and welcome to those of you who might be joining us just now for this final third panel of our summit. This panel is entitled Motivating Policy Change to Promote Equity. And we have three wonderful panelists joining us. I hope you've had time to view their bios on our website. I will briefly introduce each one of them. Dr. Robert Rock is a family physician from Montefiore in the Department of Family and Social Medicine. Dr. Sonal Batra is a member of the Department of Emergency Medicine and also a lead researcher with the Fitzhugh-Mullen Institute for Health Workforce Equity. And finally, Dr. Maria Portela is chief of the family medicine section in the Department of Emergency Medicine, also here at George Washington University. This panel discussion is presented to identify various policy levers to promote change, to dismantle racism, and promote equity. Additionally, we want to think about how stakeholders, such as ourselves, might influence and motivate this change. I know that our panelists are ready for a robust discussion. And audience, you have an important role to play in our Q&A, which you may access in our virtual format. We are looking forward to and expecting some challenging and engaging questions to have our discussion. I'll start by asking Dr. Rock to present, followed by Dr. Batra, and then Dr. Portela. I'm turning it over to you, Dr. Rock.
Okay, thank you so much. And just one correction, I'm not like faculty at Montefiore, I'm still a resident. So just let everybody know that.
We don't care, we love you.
Thank you. The feeling is mutual. But okay, so I'm going to be speaking about the structural determinants of the minority tax within academic medicine. So we can flip to my first slide. All right, so research on the social determinants of health and attempts at creating educational interventions to teach learners about them are necessary work that have existed within academic medicine for decades. However, these endeavors have historically been handicapped through a lack of institutional support and will that manifests as a combination of minimal protected time, lack of institutional recognition, and a minimal funding, whether through internal resources or external grants. The systematic starvation of these endeavors in a financially driven health system that does not prioritize education overall has placed an unfair burden on the predominantly URM faculty and trainees who have taken it upon themselves to retrofit equity onto an inequitable system. This conflict between the values of individuals and the realities of the day-to-day function of the institution have imposed an unfair burden or minority tax on URM faculty. Now, a few of our speakers today have already alluded to that. But the core aspect of it is that the people who are disproportionately taking the responsibility for equity-focused initiatives in the form of DEI committees for institutional reform, community outreach, and URM mentorship, to name a few, are the people who are suffering from racial inequity. It becomes particularly apparent in times like these when social unrest pushes institutional leadership to lean on the same small group of individuals to fix problems those individuals did not create themselves. This transient and under-resourced commitment to equity starves innovation, stunting the growth of both faculty and trainees, ultimately driving countless URM faculty out of academic medicine. And the two images are screenshots from articles that were posted recently about this exodus that has continued to happen. So the work that minority faculty disproportionately invest in mentoring minority trainees, participating on those committees, engaging with and caring for, predominantly Medicaid or uninsured communities of color go unrecognized when it is time to be considered for promotion. Studies have shown that the work of diversity, equity, and inclusion, predominantly done by faculty of color, is not traditionally recognized as the academic productivity upon which promotions are determined. but one can't discuss the structural disadvantage of this without considering the advantage of the flip side of the coin. In their recent paper titled The Majority Subsidy," Zeigelstein and Cruz explain how the current academic structure leads to URM faculty subsidizing their own oppression. The majority subsidy happens specifically when the roles and responsibilities of diversity champions are assigned to faculty on the basis of gender, race, ethnicity, or sexual orientation, essentially anything that others them from the monolithic identity of power within medicine. Um, that provides those individuals who don't hold those minoritized identities, basically white, cisgendered, heterosexual men, the time and the opportunity to devote to their career advancement that others don't have to or don't have the opportunity to, thereby contributing to a vicious cycle that inhibits progress in diversity and inclusion. Later on in their paper, they list recommendations to combat this majority subsidy. That focus on redistributing the work is essentially about making it everyone's job to commit to efforts of making academic institutions more just, more inclusive, and more equitable. And so every person who sits on any kind of committee with the authority to select, hire, or promote must recognize the value and the importance of diversity as a means to achieve excellence. It says that everyone should be evaluated according to how much they're mentoring URM trainees and students along the path. And this goes for both URM and non-URM faculty. And they should all receive training on how to mentor, how to teach, how to facilitate the progress of people who come from backgrounds that have been structurally disadvantaged. So templates for the curriculum vitae should also have spaces that identify people's participation in diversity and inclusion activities so that these mentoring roles can be included. Essentially, the big picture is that the degree to which diversity is promoted and achieved should be an important component of how healthcare institutions and academic departments are determine their compensation, incentive bonuses, academic promotions, and qualifications for leadership positions for all persons in a way that really uh, nuances the effort to create, chief diversity officers of varying levels of power. You can switch to my last slide. So, in this moment of proclaiming anti-racism, if institutions want to make such statements, they should back them with policies that mobilize the requisite resources to address the systemic problems and change promotion policies so that those doing the work are not doubly punished for it. Dean Bowen Matthews alluded to this in her keynote, but a combination of legal mandates, financial incentives, and community organizing were what pushed for hospitals across the country to desegregate nearly overnight relative to the work that was required to force the issue in 1964 with the rollout of Medicaid. The ACA used the same combination in the form of leveraging non-for-profit tax status to incentivize hospitals to conduct community health needs assessments and be more intentional about their spending habits as it relates to community benefits dollars. As the research hubs and training grounds for the next generation of healthcare leaders, academic medical centers should be incentivized to increase racial representation within their institutions to match that of the populations that they serve, or risk losing accreditation and tax-exempt status. So since we're talking about policy levers, I'm thinking, where can these policies exist? And I think the LCME can be more explicit in what is expected of undergraduate medical education programs in terms of recognizing and rewarding this is racialized equity labor as part of the evaluation and promotion of all faculty. I think the ACGME as well can be more explicit in what is expected of residency programs in terms of supporting URM house staff and faculty through mandating funded structures that mitigate the unequal burden they face in combating institutional racism. I think the last bastion of hope is the IRS, since taxes really motivate people. Non-for-profit health systems and academic medical centers would potentially lose non-for-profit status if they did not comply or demonstrate concerted efforts to increase racial representation among staff and students to reflect the populations they serve. I think the onus should be placed on institutional leadership not just designated chief diversity officers to execute these things, and that the surveillance and the accountability should exist within institutions outside of those academic medical centers, because I don't believe the fox should be watching the hen house.
Thank you so much. Thank you. Thank you very much. We'll have questions, I'm sure, for you at the end. Dr. Batra, would you like to give your presentation?
I would, thank you. So good afternoon, everybody, and thank you for joining us today for this crucial and very timely conversation. I'm going to spend just a few minutes speaking to you about accreditation as one potential policy lever, one tool in our arsenal to improve diversity and inclusion and decrease racism and other forms of bias in our healthcare system, specifically in health professions, education, and training. This has been mentioned a few times by previous speakers, including potential roles for the LCME, ACGME, and others. And I just want to take this a step further and break down what's currently going on and what we can potentially do in the future. Next slide, please. In schools across the world, accreditation, including in health professions education, is a key mechanism for institutions to demonstrate quality and value of their services. So it's a voluntary process of institutional self-regulation conducted by non-governmental organizations, though in the US, they are accountable to the Department of Education. And achieving the educational gold standard of becoming fully accredited brings distinction to an institution. I know that many of you have likely participated in an accreditation cycle, as have I, and so you understand how much weight a school or a program puts into the process. It influences institutions' decisions to pursue or not to pursue certain practices and policies. Next slide, please. At the same time, those of you who've been involved in an accreditation cycle may also acknowledge that sometimes it is just about checking the box. So you make sure that you can demonstrate you've met the requirement, but that may or may not translate into meaningful activities or policies. Well, while there will be significant variation in how schools meet accreditation requirements and how robust their programming is in any given standard, we do have some evidence that accreditation matters. So in 2018, a team from Yale released a study where they used data from the AAMC to demonstrate how the demographics of medical school matriculants changed after the LCME introduced diversity standards in 2009. Next slide. So these graphs demonstrate some of their findings. You can see that shaded area, slightly shaded area in the middle demonstrates 2009 to 2012. So in 2009 is when a number of standards were introduced by the LCME on this topic. And prior to that, there was actually a downward trajectory in the percentage of female and Black matriculants. Starting in the period about 3 years after those standards were introduced, this trend reversed. And while the percentage of Hispanic applicants was already increasing, the rate of increase was significantly higher after the standards were introduced. Now, this was an observational study, so it can't say that this caused the change, but that said, there weren't any other major national policies associated with diversity during this time. And there was nothing else nationally going on that really accounts for such a significant reversal in these trends. Next slide. Recently, we conducted a review of accreditation standards across 9 different accreditors in the US and Canada, including accreditors in dentistry, medicine, nursing, pharmacy, physician assistant studies. And we actually looked for standards related to 18 different measurable areas of social mission described in the Social Mission Metrics Initiative. But here I pulled out results from 6 areas that are most reflective of diversity and inclusion. And you can see that there's a lot of variability in the degree to which accreditors include these topics. So most include at least some mention of student diversity, although notably, nursing accreditors don't include this topic directly. And overall, diversity at other levels, including faculty and leadership, becomes increasingly less common. And we see this mirrored in what's happening on the ground in institutions, with the view becoming whiter and older and more male as you go up the leadership ladder. The student training and faculty training refer to training in either cultural competency or humility, implicit bias, or advocacy. We group those together. Now, all accreditors mention cultural humility or competency for students, but only one explicitly includes this for faculty. Next slide, please. So you can see a couple of examples of the standards here. I think these examples demonstrate the balance that accreditors need to maintain between being too prescriptive versus allowing potentially too much variability across schools in how they achieve these standards, or just being too soft. There is a need to allow schools to be different, because they should be. They're located in different places, and to be able to set some of their own benchmarks and objectives. But at the same time, there needs to be some national level accountability as to what truly achieving diversity and inclusion means. Incidentally, we did a manual review of all the standards for this project, but then we did a double check using a word search, and we included a word search for racism or racist, and it yielded 0 results. So not once was that word mentioned in any of the 9 accreditors' accreditation standards. So where do we go from here? Well, like many discussions about this topic, it feels like sometimes we're having the same discussions over and over. So in 2004, a report shown here from the Institute of Medicine included a section on how accreditation should be used to enhance diversity and inclusion, which included several recommendations to create more robust standards on this topic. One thing that they've mentioned and that I will note from our review is that we need to focus beyond students and beyond curriculum. I think the work that's being done around the country and that I'm involved in here at GW is necessary when it comes to curricular advancements to include health equity, structural racism, and various topics. But at the same time, curriculum alone is not going to do it. We know that so much of the learning occurs outside of the lecture hall, or now outside of the Zoom window. So we need to think about how the culture of an institution and the faculty and leadership in an institution should be held accountable. So what can we do to mandate policies and processes outside of the curriculum to advance diversity and inclusion? Additionally, as we heard before, it's not just about counting bodies. That's necessary, but it's not sufficient. So we need experts on equity and inclusion to develop standards that go beyond just diversity in numbers. We also need to take an interprofessional approach. So one of the things that we looked for was the inclusion of interprofessional education in the standards. I didn't demonstrate that on the chart, but it was present in all 9 accreditors. And that's because of a concerted effort over the past decade or more to include this important topic in accreditation standards. And I think we can take a lesson from the interprofessional education movement, which worked together through multiple stakeholders to actually create universal standards or guidance to create standards that have since been implemented by accreditors. We also need to consider external factors, both positive and negative. So Dr. Neve and Dean Bowman pointed out the potential enhancing impact of the law, as well as the potential impact for it to be a barrier. So we need to work collectively, you can hit the next slide, Sarah, to make sure that whatever we create when it comes to accreditation standards is essentially foolproof, whether that's for a Supreme Court challenge or other potential arguments against including these things. We also need to capitalize on movements within the government and outside of it to take this moment to make these changes. So for example, recently there was a letter from the Ways and Means Committee that was encouraging medical organizations, including the ACGME, to demonstrate what they were doing to advance diversity. I think really creating more robust standards is the most meaningful thing that these organizations can do in this space. We know that it's not going to change everything, but we need a way to raise the floor of what institutions are doing to advance diversity and inclusion and to decrease racism. And from there, I will pass it on to Dr. Portela.
Such a privilege being here with all these wonderful panelists and all these awesome participants are interested in tackling structural racism today. My name is, and not just today, just in general, my name is Maria Portela. I'm the Chief of Family Medicine at the Medical Faculty Associates. I'm also a co-principal investigator in the New Health Workforce Diversity Initiative, along with Ed Salzberg and Tuyeshe Oyeyemi. And today I want to talk about those who have been left behind, racial and ethnic minorities, and their underrepresentation in the health workforce and in the pipeline, and how that has been our inspiration for the creation of the Health Workforce Diversity Tracker. That is also the inspiration and some of the work and the legacy work of Dr. Fitzhugh Mullen. So we've heard a lot about this today, and we likely don't need to go over this again, but we know that there's a vast underrepresentation of racial and ethnic minorities in the health workforce, particularly in those professions that require a post-secondary education. And we do know that there's a lot of evidence that points to the fact that a diverse workforce can increase access to healthcare, specifically among vulnerable populations. It can also increase aspects of quality of healthcare among underserved populations. It advances cultural competency, as Dr. Batra mentioned, and also it can strengthen the medical research agenda and overall the operationalizing of the healthcare system, among having many, many other benefits. And as it's been mentioned in the summit many times before, the representation or the underrepresentation is due to many factors, one of them being structural racism and how it manifests across a continuum of access to or lack of access to equitable education opportunities that start potentially as early childhood education and that go across the whole pipeline and that reflect in recruitment, retention, entry, admissions, inclusion, and lots of other areas. The Unequal Treatment Report published in 2003 mentioned as a main recommendation that one of the possible ways that we could create change and really improve the health workforce representation would be to raise awareness of this critical data by publishing regular updates of the underrepresentation. And like next slide, please. And some professions, like the allopathic medicine profession, have been doing this, but many of other health professions have not. And this was also part of the inspiration for us to create the diversity tracker. So we really wanted to create a tool that would increase transparency, that would raise awareness of these disparities in the workforce and the underrepresentation, and that would also increase the opportunity to achieve and have accountability. And our hope was that presenting this data to academicians, researchers, and policymakers would really serve as a catalyst for change. So essentially, the methods that we utilized when we started working with the diversity tracker where we used publicly available data from the American Community Survey and publicly available data from the Integrated Post-Secondary Educational Data System. You can take a look at our detailed methods at the website that's listed in the bottom. We essentially took this data and we formulated something called the diversity index. Next slide, please. And what is the diversity index? So the diversity index is a set of ratios that we utilize to conceptualize and be able to compare in a simple way to the public how looking at the general population and the representation of racial and ethnic minorities, how it would compare to the actual representation in the current workforce, but also looking at projections and looking at the estimated potential workforce by looking at the pipeline. So we created two different indexes, the workforce index and the pipeline index. And a brief example would be in 2018 and in 2019, 12% of the general population in the total workforce is African American or Black. If 12% of nurses, registered nurses, were also African American or Black, then we would divide 12 divided by 12, and we would get a equitable representation or a diversity index, an ideal diversity index of 1. If 6% of the nurses were African American, then we would divide 6 divided by 12, and we would get a diversity index of 0.5, which would indicate that we are meeting half or less of the representation that we should be meeting to have equitable representation in the health workforce. Next slide. And essentially this presents the same thing, but looking at 10 professions in the health workforce, if we look specifically at African Americans at the most recent available data from 2019, we can see in the red line indicated at the far right that none of those 10 health professions we're achieving equitable health workforce representation. And in fact, we're doing quite poorly. Next slide. This slide is a little busy, but it really means to show across those 10 professions in the health workforce that are depicted in the bottom: physicians, pharmacists, respiratory therapists, dentists, registered nurses, physicians, physician assistants, etc. We drew an ideal line represented by the red line of an ideal representation of diversity index equaling 1. And anything that's above the line would equal either ideal representation or overrepresentation of the health workforce across that race and ethnicity. And below the line, we can see a quick glance at the underrepresentation. So Blacks and African Americans are depicted in the color orange, and you can tell that there's gross underrepresentation and that there's no overrepresentation or ideal representation basically on any of those health professions. And you can also tell Hispanics are depicted in gray. Also, the vast majority of the professions, of those 10 professions, specifically 8 of the 10 are below half of the goal or have a diversity index of less than 0.5 of the ideal. And of the Native Americans, 7 out of those 10 professions have a diversity index that's below the goal. Next, actually not below the goal, but below 5, below 0.5. So actually half of the goal, even worse. Let's skip next slide due to time. Next slide. Okay, so we also took a look at the diversity index across the pipeline. And for this, we utilized both American Community Survey data and also the Integrated Post-Secondary Education System data. So Hispanics and Latinx in the pipeline, they represent about 20% of the general workforce population, but you can tell by the red line on the right that there's significant underrepresentation across the 10 health professions. And as I mentioned before, the vast majority are well below half of the, not even meeting half of the general workforce ideal representation. Next slide. This is also a conglomerate aggregate data snapshot at looking at these 10 health professions and across the pipeline. So what we try to do is take a look at, well, what if our current workforce in terms of underrepresentation is looking really bad, but in terms of underrepresentation, our pipeline looks promising. So that's what this slide is trying to depict. And if we look at the red line, which would be ideal representation or overrepresentation, we can tell that there's only overrepresentation of essentially white Americans, which are depicted in blue, in all of the professions, but there's only overrepresentation or ideal representation of Native Americans, which are depicted in yellow in one profession, and African Americans in 2 of those 10 professions. But the vast majority, although it looks better than the current workforce, they're still severely underrepresented. This slide, I just want to point your attention to the direction of those arrows. And what we're really trying to depict with this slide is the fact that if we look at the comparison between the current workforce by race and ethnicity, and we look at the direction of where and how the pipeline is looking in terms of submitting or increasing our projections of workforce estimations in those racial ethnic minority groups, in 5 out of those 10 workforce categories that we selected, 5 of those 10, the pipeline looks promising in terms of increasing workforce representation across those professions. But 5 out of those 10 are actually, the pipeline looks like it's going in the opposite direction. So in terms of policy implications, I mean, the speakers that have come before me have outlined it very well. I think for us, the diversity tracker and the diversity in the Health Workforce Diversity Initiative is really meant to be a tool and serve as a catalyst for change for policymakers. And part of this will start with, 1, denouncing racism, as has been mentioned before, as a social determinant of health, as something that needs to be eradicated. Also addressing that racism affects every other social determinant of health. And then within the current workforce, looking at issues across the board, from equal pay, non-discriminatory laws, hazard pay, opportunities for advancement, leadership representation, and in the pipeline, also issues, but not limiting to, and starting very early in the pipeline, early childhood education opportunities, primary, secondary, post-secondary education, and issues around entry, admissions, policies, retention, inclusion, and obviously many legal determinations such as affirmative action. And we hope that that with your feedback and your excitement and your ideas, we can continue the work of the Diversity Tracker and the Health Workforce Diversity Initiative to really expand this work and create and be able to be a catalyst for meaningful change. Please visit our website. Next slide. Those are some references, and I would like to acknowledge the whole team, our sponsors, and our funders. And I'm here available for questions as well.
Thank you so much to all three of our panelists who've given us a lot to think about and chew on. I know we have questions bursting in the Q&A, and Chelsea has one queued up for us. So Chelsea, would you ask the first question?
Yes, so the first question is from Anna for Dr. Rock. Any specific successes in changing promotion criteria to incentivize engaging in DEI criteria?
Not that I've seen in the recent, like, given like the events of this year, I haven't seen any major changes. Most institutions like publish their APT criteria, like you can find it online. But I haven't noticed any like major adjustments as of yet.
I'll just chime in and say that certainly the call from many publications for manuscripts around diversity, inclusion, racism, and equity, well, I should say anti-racism and equity, have been encouraging because as those of us who do this work are able to publish it, that certainly would go a long way towards promotion.
I will just add on to that, that even outside of the traditional academic sphere where we're thinking about publishing, as part of the Social Mission Metrics Initiative, we surveyed schools last year, 240 schools. And one of the questions that was on our survey was, what are there social mission type initiatives included in your APT criteria? And so our faculty officially or formally recognized for contributions related to community engagement, advocacy, and things like that. And you know, we had a limited sample, but about half of schools said they were, which means half of schools said they're not. And I think that this is probably a biased sample with schools that were, you know, more thinking about social mission metrics, more participating.
And even if those are considered, I wonder how broadly the faculty understand that that work is considered as part of a promotion packet. You know, so we have work to do even when it comes to communicating with our faculty about what is valued, even for the institutions who say it is valued. How is that communicated? Chelsea, do you want to go to the next question?
Yes, so I have another question. I think this could be for Dr. Rock or Dr. Batra. This is from Dexter. How can we leverage the moral obligation of humanism as a means to our ends of DEI work? Accreditation compliance is institutional, but the real change can only occur if individuals are engaged and committed at a personal level. How do we reach that audience in a meaningful way?
Anybody want to take a stab at that?
I can start off. So I think that while we need to reach individuals on a personal level, and there is, you know, certainly a moral appeal that I think anyone who decided to join this call is probably going to be more susceptible to. At the same time, I don't entirely agree that that is going to be the primary means towards achieving change. I think that we need structural change, we need policy level change to kind of bring everyone along, whether it's willingly and it's leading the way, or whether it's kicking and screaming, frankly. Because at some point, if you change the expectations and you change, you know, the bare minimum that a school or an institution needs to do, over time, that becomes more and more the norm. And so, you know, I think that we need both. But I think that the larger underlying structural changes are actually going to be more important in the long term than the personal changes.
I would agree. I'm thinking from personal experiences. So I started medical school in 2013. I have distinct memories of mentors who were transparent as it relates to how much time they could give to me because of the opportunity cost in relation to their productivity. As I was graduating, they were, and I guess, like precarious places in terms of just feeling like they weren't progressing. And I think it was a matter of shifting institutional priorities that was what was needed to like boost them to different leadership positions related to the work that they had always been doing.
I'll just chime in. I firmly believe that we do need to do the work of raising awareness, trying to get people to understand their own personal bias, whether it's unconscious or conscious. But I'm a bit discouraged by the decade of work that we've done, particularly in the arena of unconscious bias, which by many accounts has not moved the needle at all when it comes to improving where we are with diversity, inclusion, and equity. So I think it was a great start. It was a good start. I think we have to continue that, but certainly the work that we need to do involves moving past that into, in my opinion, the policy arena, which isn't perfect either, because we can talk about accountability there. How are we going to ensure accountability? You can have all the policies you want. If there's no accountability, that doesn't change anything either. All right. Wow. The questions are piling up. We got to go. We got to go.
I will ask another one for, give me one moment. From Michael Weaver, what are the diversity metrics that should be included in all faculty and program directors' evaluations as part of promotions and annual evaluation?
So from the research that has been done and different things that were put forward, I think the incentive on supporting on mentorship of URM faculty in terms of taking the time and making the opportunities for people to take advantage of opportunities to publish, be more productive in the eyes of the institution. I think that is an imperative in terms of like being evaluated. And then also showing people who are doing the work in terms of sitting on committees to do a lot of the tasks that some people avoid, and doing a lot of community facing work. I think that academic medicine can sometimes be a bubble, but we can never forget that we are accountable to the public, that we are subsidized by the public, and people making the efforts to engage with community, whether through pipeline work or community outreach or community-based participatory research, should be recognized in evaluation as well.
100%. That question also made me think a little bit more about the social mission metrics. Dr. Batra, are there specific questions that address that portion in social mission metrics?
Not directly beyond what I mentioned before about how faculty are rewarded or recognized. I think one of the limitations of that project is that we did include 18 different areas of social mission, everything from diversity to community engagement to your research portfolio. And so we weren't able to dive super in depth into any one area. And I'm certainly not an expert on what those particular benchmarks should be. That said, I do think we need to engage those who have been involved in faculty evaluations to try to figure out what are the right benchmarks, what should we be holding people accountable to. I think just because we don't have them yet doesn't mean that we can't use them. It just means that we need to get together and create them.
So I'll just chime in and say I think that the base metric is really just compositional diversity, which does matter. So for department chairs, for instance, the diversity of your faculty, your residency program, and perhaps even staff members and others on your team you should be accountable for that. And we should perhaps think about making departments accountable for how involved they are in community efforts to decrease racism. How many people on your faculty are writing about or involved in scholarly activity around diversity, equity, inclusion, and anti-racism? I think there are many different levers that we could use. It's maybe blends into this next question, which I'll ask, which is, and this is from Dexter Francis. In our society, one strives to gain advantage in position, power, social capital, etc. what is the incentive to the majority race to dismantle structural racism and so give up their advantaged and privileged position?
So I'm a student of Freire, Pedagogy of the Oppressed. He says that it is unfortunately, it's the role of the oppressed to liberate themselves and their oppressor. This is so hard because the people in power are very comfortable with that. And nobody is going to voluntarily cede their comfort for others.
So how does that then play back to your issue about the minority tax, which, you know, would say, if we're not going to do it, no one's going to do it. So we just have to pay the tax. And I've heard that argument. We just have to pay the tax.
I think that the point of the minority tax being inequitable is that the work isn't evenly distributed. And if the work can't be evenly distributed, then the people doing the work shouldn't be punished for it. It would be a beautiful place if everyone with any kind of power within the power hierarchy was committed to using their personal privilege and access to move the needle. We're not there yet, but I think that creating structural changes that don't limit and actually do reward the people who are doing this work is an incredible lever for change.
I think, you know, we have to create that motivation. And I don't mean to sound totally negative about it, but sometimes, you know, you may not be able to create that motivation with, you know, a moral appeal. But I think that that's where the power of initiatives like the rankings paper that Fitzhugh Mullen and Candace Chen and others put out 10 years ago, and the White Coats for Black Lives racial justice report card that we discussed earlier, can take into account. When you make publicly available information on how an institution or a program or a department is performing in a certain area, while I know that's fraught with discomfort for many people, at the same time, it draws attention to it and it creates a really powerful incentive for those who are in a position to create that change to actually do so, whether they have that moral conviction or whether they don't. And I think that that is one strategy. You know, we talked about accreditation, obviously, as another potential strategy where, you know, it's a bit of a stick in some way. And I think we need both carrots and sticks. But I think that, you know, a number of these small pieces together are what are going to create that change.
I agree. And I think also just the increased transparency really kind of forces people to be accountable. And even if folks don't focus on a moral, ethical obligation, you can't really advocate for equity in one aspect and not really look at equity across all other aspects, right? And in terms of the healthcare workforce, we all want our patients to be healthier, and we know that when all of our patients are healthier, it benefits all of us. But it doesn't just benefit all of us in terms of our health, it also benefits the economy. There's a significant cost of not treating people equally and not addressing health disparities that if there were no other incentives, at least the economic incentive could be a potential driver.
Very good point. Listen, thank you, Dr. Rock, Dr. Batra, and Dr. Martinez for such a wonderful discussion. I wish we had an hour to answer all the questions in the chat and to continue to have this conversation. But you guys are all amazing and doing wonderful work, and I applaud you. We are now going to introduce our final session. And so to conclude the summit, we're now going to discuss next steps and plans for developing actionable recommendations. Leading this discussion is Toyoshe Oyeyemi. And Toyoshe is the director of the Beyond Flexner Alliance here at the Mullen Institute. He's a public health practitioner and senior Atlantic Fellow for Health Equity. His research, teaching, and practice focus on health policy interprofessional education, and health workforce development.